Today we'll be hearing from the Department of Public Services. We'll be starting with Human Services on page 402, and I will turn it over to Tim Kaufman.
Good morning, Commissioners. Chairman, Commissioners, thank you for this opportunity to present the Department of Public Services 2019 budget request to you. I'd like to recognize the directors that I have with me here today because they and their staff and the budget analysts have worked very hard to get us to this point, and I appreciate all the work that everybody's put in. Per the budget instructions, we have submitted flat budget requests. You may see some fluctuations, particularly in the personnel line, and those are going to be related to budget changes that happen throughout the course of the year. And you will see a few increases in the grant budget sides, in part because the state may have provided some additional resources for services that are provided. And that leads me to another point that I want to remind everyone, that the services that are delivered in the department, particularly the human services, are done in partnership with state organizations, state agencies, and so we work with and on behalf of the state to deliver services. We've got kind of a shared responsibility for a number of different programs that we deliver, so you'll see some fluctuations based on state actions as well. Commissioner Ranzo, this is what it looks like if it's every slide, full slide. So I made it smaller so it wouldn't frighten you. But if you guys need a break halfway through, let me know, because there's a lot of material here. So we're going to start on...
Question is, will you need a break?
I may.
Well, we had to force them in my meeting.
That's true, yeah. We're going to talk about human services, community programs, COMCARE, the Sedgwick County Developmental Disability Organization, Division on Aging, Division on Health, our parks, the zoo, more community programs, and Exploration Place. And as Lorian said, we'll start on page 403 with human services community programs. And the mission there is to interface with social service providers, monitor funding agreements, and to assist community partners. We include in that cost center the Nonprofit Chamber and the Child Advocacy Center. The Nonprofit Chamber was developed a number of years ago, probably about 12 or 15 now, to help in recognition of the need that we know, particularly in COMCARE and corrections, that we need to partner with other organizations to make sure that all the services that need to be delivered in the community are, and we can do that if we have a strong network of community partners. And so we initiated helped initiate the Nonprofit Chamber. In 2017, you can see that they had 97 different members, and they served almost 660 people through training events, and we continue that relationship with them. The Child Advocacy Center is the other organization that's funded through this budget. Child Advocacy Center is designed to create a multidisciplinary response to children that are victims of abuse, and it focuses on advocacy, therapy, and case coordination. In 2017, they served over 2,000 abused and neglected children, and then over 1,100 caregivers that were involved with those children. And Sedgwick County is one of many different funding partners that they have, and those services are provided by that Child Advocacy Center. The budget request is flat for 2019, still at $220,000, and there you can see it by superior commitment item. And I will pause after each one of these as I transition. If you've got questions, if you want to hold questions, that's fine. If you ever have questions in between, please let me know. And if I don't have any answers, I've got the experts with me. So moving on to page 407 and COMCARE, the statute that establishes community mental health centers is listed there, and their mission is to help people with mental health and substance use needs to improve the quality of their lives. They do that through a number of different programs, and we'll talk about administration and operations, in part because it houses a couple of different somewhat like treatment programs, some housing programs, Shelter Plus Care and Housing First. Then there's the Addiction Treatment Services Program. Center City is our homeless program. We provide a tremendous number of crisis services, community support services, children's services, and then outpatient services. The strategic results that COMCARE has identified as part of the strategic plan. The first one is identify and provide 36 presentations a year or 3 a month to the community about mental illness to continue to raise the level of awareness and to reduce the level of stigma. And in 2017, COMCARE delivered 54 presentations, and they addressed over 1,400 individuals through those presentations. Joan's got a lot of very gifted staff who are out in the community spending a lot of time raising awareness and working on that stigma issue. Another strategic result is to increase by 25% the number of children with SED that are receiving rehabilitation services at COMCARE. And in 2017, they accomplished a 9.4% increase in children, in large part by implementing same-day access intake services to make sure that when a family was ready for services, we got them in that day, because it's a difficult decision sometimes for families to seek help for kids, and we want to make sure that when a family's ready to do that, we're ready to help them rather than schedule an appointment a few days out. They may change their mind, circumstances change. So that has been a significant advance in the service delivery that they're doing. And then they want to increase by 15% the number of law enforcement assists that they do. And in 2017, they actually increased by 27% the number of law enforcement assisted interactions they had with consumers. It's an ongoing and ever increasing issue that consumers of behavioral health services interact with law enforcement system, and it can lead to disastrous results. And again, we've got some very good staff that are able to assist law enforcement and make sure that those things end as well as possible.
Tim, is that increase, is that mainly due to the Community Crisis Center, or is that crisis intervention training? Or
it is crisis intervention training and the awareness that those law enforcement officers and the community have to ask for assistance. If the community asks for a CIT trained officer, that officer is more likely to make contact with COMCARE Crisis and potentially bring someone out to the scene. We've got a mobile crisis unit that will go to the scene, and so if a CIT trained officer is on site, they're more likely to engage our staff to come and help.
Thank you. Excuse me.
Go ahead.
Administration and Operations is the first program that we'll talk about. It's funded with property and non-property tax funds. They provide all the infrastructure and support that the division needs to deliver services, and they collected $18.8 million for COMCARE services. Those staff also coded over 42,000 EMS runs, and they manage a large number of contracts, medical requests, med records requests, as you can see there. And there are 2 different treatment type programs. Shelter Plus Care is a non-property tax funded program that combines a housing voucher with treatment, and so individuals who are experiencing a mental illness and some other type of disability as well, so a substance use disorder, HIV/AIDS related illness, or SPMI, in addition to being homeless, qualifies them for this program. They become eligible for a housing voucher, and that requires that they receive treatment as well. And so there are a couple of different partners that refer. Miracles and School of Medicine provide some referrals for that program, and we served 212 individuals in 2017, 143, and that represents 143 different households. And every year there are folks that are in that program that, through that combination of taking them from homelessness into housing and getting them the treatment that they need to address their mental health issues, it allows them then to successfully transition into other housing opportunities, and that happens every year. And the Housing First program is a property tax funded program, and it is the partnership that we have with the City of Wichita, where we split the cost of 64. We try to have 64 individuals housed at all times that have gone directly from homelessness into housing, and the only requirement for those individuals is that they accept some type of case management, and through that case management then we're often able to help them get into the treatment, whatever treatment it is that they need. And we served 80 individuals in 2017. This population is a little less stable. They're probably what some refer to as the hardcore homeless. They're people that meet the definition of chronically homeless, and so that means they've either been homeless for a long period of time or they've experienced repeated homelessness. And so we were able to help 80 folks last year with that particular program. COMCARE's homeless program is called Center City. It's co-located at United Methodist Open Door, and it's a one-stop shop for homeless services. So in addition to the behavioral health services that our staff provide, there are a number of different helping organizations in that setting. The VA's got people there. There are some health care providers that are there to provide health services. There's legal services that come through periodically, and so it's a place where individuals that are experiencing homelessness can get whatever services that they need all in one place. And our staff work with those that are experiencing mental illness two different ways. One is through outreach, and sometimes an outreach experience may take a couple of years to get folks that are living, and we've got outreach staff that go into the community. They'll go under bridges, they'll go into shacks and cardboard boxes to meet with folks and try and talk to them about changing their circumstances through treatment and through one of the housing options that we may have available to them. They outreached 332 folks last year, and they were able to engage 363 people into services. Addiction treatment services is funded through property tax and non-property tax, and that, as the name implies, they are there to serve individuals who are experiencing addiction to alcohol or other drugs. Served 1,400 adults in 2017, and they do that in an effort to help individuals gain and maintain sobriety and have a drug-free lifestyle, and they do that through individual and group counseling, and now we also do Medicaid-assisted treatment for individuals if that's the appropriate therapy for them as well. Our crisis service is one that you may be more familiar with. It is designed to make emergency mental health services available 24 hours a day to anyone who's a resident here or passing through. And in 2017, almost 10,000 face-to-face crisis services. There were 1,500 admissions to the Community Crisis Center, and they handled over 75,000 calls on the crisis line. And they do that service at the crisis center. They do it over the telephone, and they do it in the community. I mentioned that we've got a mobile crisis service, and so we'll go to the schools if necessary. We'll go to on scene if there's a law enforcement engagement. We'll go do welfare checks on individuals in their homes as well. So that mobile crisis service is really utilized by the community in a number of different ways. And as I mentioned, our Community Crisis Center is now in its third year of operation. We helped 976 individuals in the crisis observation beds, and those are the recliners, and that's a 23-hour stay. Those are folks that maybe we can help get them squared away in less than a day. Sometimes they just need to get out of whatever environment that it's in that's increasing or exacerbating their mental health illness or issue at the time. And so that crisis observation bed may be the perfect solution for them. Crisis stabilization unit is designed for a little bit longer stay, so we generally help people for 3 to 5 days in that setting. Sometimes it goes a little bit longer depending on what their circumstances may be. We've helped 468 people through the sobering unit and over 1,100 in detox. And then we partner with the Wichita Children's Home to reserve a bed so that we've always got a bed available for children's respite services. And so we will staff, if it's appropriate for a child to be out of their home setting, we'll work with the children's home, utilize one of their beds, and then we'll send our staff there. And so we staff that because they make the bed available for us. And so that's a really good partnership, and that helped 49 kids last year. The Sedgwick County Offender Assessment Program is also part of our crisis services, and those are services that are designed specifically to help keep people out of the jail and out of the law enforcement system, or the legal system, particularly if they're there primarily because of their behavioral health symptoms. And so we've got case managers that are specialized in working with the courts and working with those systems and making sure that people show up for appointments and they don't get bench warrants and that sort of thing, and keep folks from clogging up the criminal justice system just because of mental health experiences. And they've done a tremendous job in helping maintain that jail average bed day, keeping that number down. Moving on to the community community support services. This is a non-property tax funded program. This is the program that was at Twin Lakes, and they are in the process of moving to East Harry. They'll be done and moved in by the end of June. This is a program that is designed for the people who are experiencing the most severe mental health symptoms and diagnoses, and the services that we provide through CSS are designed to keep people from a higher level of care. So again, to try and keep them out of the state hospital and give them an opportunity to maintain in the community. And we do that through case management, through therapy and med management. And we served over 1,700 folks in 2017. Our children's services are designed to serve a similar set of consumers, but at a younger age. So the children's program is designed primarily to serve those children that are experiencing serious emotional disturbance and are at risk of hospitalization. So these are the kids that are the most sick, and we provide services to them. Again, case management, we've got wraparound services, we've got med management, and we've got therapy, and we do that in a number of different ways. But again, the goal is to help those kids maintain in the community, in their school, and in their family, their home setting. And we work an awful lot with the foster care system with this program. Those kids that experience some of the trauma that puts them into the foster care system experience a lot of behavioral health problems, and so we partner quite a bit with the foster care agencies in the community to make sure that those kids get the services that they need. We also, and so we served almost 2,900 kids last year, and we also have a therapeutic preschool to help kids that are already exhibiting behaviors associated with their mental health concerns that don't allow them to go to preschool, for example. The kids that go to the Proud of Me program have generally been kicked out of the other preschools in town, either one or many, and through the therapeutic approach that they take at that in that setting, they're able to help get those kids ready for school and allow them to go to traditional school. The changes that they make to those kids are pretty remarkable, and so we helped 48 kids last year, and we think that we'll see that number to continue to increase. Outpatient services is our highest volume setting. We provide individual and group therapy for adults in that setting, and we served 675 individuals in 2017. And at our outpatient program, that's our high volume medical clinic as well. And so we see a lot of different people for med management services at that location. And again, this is to help folks maintain that at work. These are generally folks that are able to work. They're able to particularly with some help through therapy and medication, they're able to maintain in a regular setting just like anyone else may. I mentioned our med clinic. We have medication services provided by psychiatrists and nurse practitioners at all of our different programs. We served over 7,500 people in 2017, and you can see outpatient we served over 5,000 people at the outpatient program, and we serve an awful lot of kids, 1,300 kids as well at Children's. COMCARE's budget request on the property tax side is $5.1 million, and those are the programs where that funding goes. And the non-tax request is $37.5 million, and you can see where those programs go, or where that funding goes to those programs. And again, Children's is the one that receives the largest amount of funding there. Here are the various funds that make up the COMCARE budget request, and there's a slight increase, 3.9%, and that is primarily based on some additional funding that the state has provided. as we go through all of these different requests, you may see when we start looking at the superior commitment items, you may see changes in personnel. Those costs, those increases and changes are almost exclusively tied to benefit changes that happen throughout the course of the year as the workforce changes each year. So there's a slight increase for COMCARE, and again, that's going to happen on the state side, on the grant fund side, and that is COMCARE delivers these services in partnership with a number of other organizations, and so we pay that through the contractual line item. So in terms of decision packages, COMCARE does have a decision package, and it is tied to the demand for children's services. This shows the increase in therapy hours that we've shown. There continues to be a demand for children's services. There are almost no child psychiatrists in this community, and we're fortunate to have one, and she stays very busy as well, but the demand for children's services continues to increase, and it's increasing across the board. All different programs are seeing those types of increases. So we have a decision package on the COMCARE grant fund side that asks for 1 supervisor and 4 senior social workers, so those are therapists, and we would like to use those staff to address the increasing mental health needs in schools. Schools continue to approach COMCARE and ask for services to be delivered in the school setting, and the primary reason for that is because it eases the burden on the parent to come get a child, pull them out, take them to an appointment, get them back into school. If they're available if we provide staff in schools, it makes that service delivery much smoother for the child, for the family, and for the school. They miss less school that way. And originally we had talked about adding these positions in USD 259 schools, but in the state legislature, in the state budget process this year, there's a pilot program that's been included in the budget, and we're kind of waiting to see how the governor reacts to it, that would provide some funding for additional staff in 259 schools. And so if the budget is approved, if that's approved in the budget, we'll be coming to you to talk to you about that separately. This request would allow us to put therapists in some of the suburban school districts as well, because behavioral health issues occur there as well, just not at the same volume. But larger school districts, Derby, for example, certainly would be able to take advantage of us allowing staff into that setting. We know there are staff there, there are kids there that need services, and this just helps address some of the unmet needs that there are in the community, helping those kids maintain in school and move forward. These positions would pay for themselves through the revenue that's available, and so that's it. So the request is for an addition to the staffing table and an increased budget authority, but these are self-funded positions.
Hey, before we go on to SCDDO, do we have questions over COMCARE?
Yes. Just
Commissioner
one question on the last slide is that just high school, or is it?
No, we would work with the school districts to make sure that we place staff in the setting that demonstrated the most need. When you get to high school age kids, sometimes that stigma issue raises its head a little bit more, and so sometimes it's more effective to intervene earlier at elementary school or the middle school level. If we've got if there's a high school administrator that says, I really think that we can occupy a staff in this way, we would put a person in high school. But generally, we're talking about younger kids.
And a lot of that just has to do with strategy to reduce the stigma.
Yes.
Where's the money coming from?
Well, the services that they deliver are paid for by either private insurance or Medicaid, depending on what the child has. But it's really uncommon in the adult world, there's a lot of services that are delivered that aren't paid for. But in the children's world, almost all children have some type of coverage available to them. So it's a fee-for-service arrangement.
Okay, so can the school districts do the same thing on? I mean, it didn't have to be a COMCARE employee; they could do this themselves.
Well, they can't bill Medicaid for this. They couldn't bill Medicaid for the service or insurance for the service in the school setting. The school couldn't
Why is that?
because they're not, if the school gets Medicaid funding, it's not tied, this is additional services on top of anything that the school could provide.
But they could like provide it on their own if they wanted.
They could, but there's no payer source for them to do that. We're able, because there's either insurance or Medicaid to pay for the service, we're able to put a person in there and have the service paid for. If the school district were to deliver this type of service, they would have to do it out of their current funding, their existing funding.
Well, the payer source, I mean, whether it's Medicaid or schools, is still the taxpayer. It comes from the same spot.
Other than the third,
Right.
It's not as uncommon for kids to have regular insurance.
Commissioner O'Donnell?
Thank you, Tim.
Were you finished? I'm sorry.
Just to clarify, private insurance, can they charge private insurance?
I don't know that the school staff are licensed in a way that they could.
Well, they could hire someone who's.
Joan's shaking her head.
They
no.
could. Okay.
They can't bill private insurance.
They can't hire someone who's trained to do that?
Here's the reality in the schools is their school counselors are tied to academic performance, so they don't provide the traditional mental health services that we would. So they have capacity issues. They're saying they can't.
Well, I understand, but I'm saying that they could hire someone who has the expertise and the training to do it, and that's all I'm asking. I mean,
They can't.
they can. The current counselors may not have that skill set, but if they found someone who did, they could do that. That's all I'm asking.
Yes.
Okay. Commissioner O'Donnell?
Thank you. So, Tim, I like the idea. My question is, where did you come up with the number of 5? Because it seems that if these positions ostensibly pay for themselves, we know there's a greater need than probably just 5 schools in the Wichita area when you just look at demographics and some of the issues. Where did that number come from?
Sticker shock. Sticker shock. We didn't want to overwhelm. There are a couple of different issues, and one is that we want to make sure that we don't add too many because they need to pay for themselves. We believe that we can, but it's one of those things where if we came to you and asked for 20, you may react differently than if we ask for 5.
Right. So it's a program that could potentially grow in the future.
Exactly.
The second question is, so the organization of it, we would have to have somebody on staff at COMCARE, a director of this, correct?
The supervisor. So what the program manager, and so this would fit under
So those
the.
program manager fees would be covered as well in the, because I see that you're saying this is all covered by it.
Yeah.
So there would be no expense to the county.
Correct.
Even with the supervisor position.
Correct. Yeah.
Are other counties in Kansas doing this?
Other CMHCs are doing it. Mental health centers do this as well, yeah.
Okay. I'd like to learn a little bit more about this. I'm sure you and I can talk or
Sure,
and
absolutely.
see what other counties are doing, because we know there's a huge mental health need in the schools, and
Mm-hmm.
we see it played out in very violent and extreme ways across the country. And if things like this could intervene before you get into some of these tragedies that have happened in schools across the country, I think that would be really beneficial to the entire community.
Absolutely.
Thank you.
Thank you. Commissioner Howell?
Thank you, Chairman. You mentioned something about a mobile unit. Can you please tell me about that again?
Sure. At our crisis program, we have staff and a van, and we've got the call center. And so if someone calls in and they describe a mental health emergency that's going on in the community, for example, a family member knows that someone may be potentially suicidal at home, and they can't talk that person into coming into our crisis program, we've got staff that will go to that home, sometimes with law enforcement, sometimes on their own, depending on how the situation is described. And they'll deliver that mental health service on the spot for that individual. And we do that between about 10 and 10 throughout the course of the day, of every day.
So if there's a few people in the community I know that call 911 practically every day.
and it's related to mental illness. I'm pretty sure. So, in a city like Wichita, it's a pretty big problem. But in a city like Derby, it really cripples because they only have 4 law enforcement officers on the streets at any given time, typically. And if someone makes a call, it takes half the police force to deal with that person every single day. And I'm wondering, this is a county-wide service, correct?
It is.
If that person continues to make a call to 911, and we know that's what's been going on in the past, do we send that mobile unit to Derby potentially to provide that service?
We could. My guess is that if they're calling 911 a number of times every day, they're probably also calling our crisis line a number of times every day. And so it's not uncommon for us to work very closely with law enforcement because sometimes those populations, they frequently cross over. And so we deliver mental health services in Derby just as we do anywhere else. So if that's going on, I'd encourage, and in fact, Chief Lee is on the COMCARE advisory board, and so it would surprise me if we're not working closely.
Well, this action item, if you want to call it that, came from Chief Robert Lee. Discussions I've been having, he's quite frustrated because it seems like the mental illness everywhere, of course, it seems like it's getting a little bit more prevalent, but on top of that, the county's second largest city is crippled with the issue, and they feel like we're not able to solve it, and they're asking for some help from Sedgwick County for us to engage that problem on a few of these types of folks in the Derby area that are really really causing that type of a problem. So I guess we need to make sure they're aware of that.
Yeah,
availability.
It would surprise me if he's not talked to Joan, but if he hasn't, please have him talk to Joan.
If he hasn't talked with you, okay. I hope that we're just letting you know we're there to help, and if there's something we need to do there that we're not doing, if we need to enhance that because the need's greater than it maybe used to be, talk to us about that. Maybe one unit isn't adequate any longer. I don't know how busy they are, but I hate to go back this far, but I'm curious. I'm trying to keep up with you. You go pretty fast, by the way, which is good. But I was curious back on page 404 in the book. It seems like there was a shifting of some personnel costs that happened in 2016 on the community programs. I don't know where that may have gone. Does that still exist somewhere else, or did it go? Yeah.
It was shifted to COMCARE, Commissioner. That was part of the elimination of the Human Services Director's Office.
Oh, okay.
And then those programs were renamed as community programs, and COMCARE, and I think actually Health Department absorbed those positions.
Okay, and then likewise, I think I saw on another page here on page 408, there was a huge jump in admin and operations under the top line there. Jumps from 5.4 to 7.2.
That's those 2 housing programs that I mentioned, Shelter Plus Care and Housing First. Those used to be in the...
I knew there was explanations. I just had to have you remind me what it was. Yeah. Thank you very much. Chairman. Thank you.
Thank you. Tim, I know that we've been in meetings with the sheriff recently about really 2 issues. One is the drug and opioid problem, and the other is about mental health issues. And they impact a lot of different agencies. I know we're putting in for a grant right now to see if we can get some help on the mental health issues. But I thought maybe there might be some decision package in here to add a position in case we don't get that grant to start looking at the mental health issues and how that it can impact the jail population and so forth.
We're actually going to talk about that in a workshop that I don't know if it's been scheduled yet or not. But we've got some background information on a position that potentially would be able to do some coordination efforts, and one for the behavioral health law enforcement component, and the other the drug component law enforcement intersection. And we've got some workshop to schedule on that.
We're going to discussed that with you last week. We're going to talk about both the sheriff pay scale as well as those 2 positions in a workshop, because we're going to have to bring in the providers and some stakeholders so we can have that discussion. Whether we have are able to insert those 2 FTEs in this budget or after this budget, we can always adopt it. If you adopt the 2019 budget once we kind of figure out what this looks like. It's so fluid right now that we can always adopt it later on. But we will have a workshop on it to discuss it.
Okay, sounds good. Commissioner Howell?
Thank you, Mr. Chairman. I just wanted to go back to the two housing programs, the Shelter Plus and Housing First. Do we have performance measures on those and find out what happens down the road? So someone receives, if you will, a housing solution through this program, and I'm sure it's time limited. This is not chronically provided. I'm sorry, it's not long-term provided forever. This is something that gets them into a better situation for a while, but then that situation has to become their own responsibility to continue something good there. So do we track that going forward and find out how many people are actually able to stay in housing that are in this program?
We do not have the resources to follow those folks once they've left the program. We do know oftentimes who those people are. They may cycle back through, and particularly with the Shelter Plus Care program, just because someone transitions from that housing situation, they no longer receive that housing voucher, doesn't mean that they're not continuing to receive behavioral health services. In fact, we hope that they do. And so we interact with them in that way. You know, we're going to provide that level of care for as long as they choose to accept it.
These two programs, again, I would go back to the root cause of the problem probably is an income. They have an income problem. Okay, maybe they need employment. They've got job skills needs or whatever. Education and employment might be the root cause, and so providing housing by itself isn't going to solve the problem long term. They need to have something else on the side of that. So,
for the people in these two programs, there needs to be an underlying mental health issue in addition to homelessness. Those are really the only two key criteria. You have to be homeless. You have to have a mental health diagnosis, and for the Shelter Plus Care, you have to have an additional disability as well. And so, absolutely, and the intersection between poverty and people with disabilities is absolutely very real. But for these particular individuals, there is an underlying cause of mental health, generally untreated mental health issues that lead to their income problems and their homelessness.
To me, it's a two-edged sword, because for someone who wants to receive type of help, if they have to have a diagnosed mental illness, they can receive some help, but it also limits their ability potentially to get employment because somebody may be reluctant to want to hire somebody that's got a diagnosed issue. So
that certainly is a concern, and one of the things that I talked briefly about the CSS program, and one of the things that CSS does very effectively is work with persons that are experiencing mental illness in terms of employment. And so we've got job coaches and we've got employment coaches that work with employers. They identify employers that are willing to employ individuals as they go through their mental health recovery experience. And so ideally what happens is folks that we serve in one of those two programs enters into a higher level of services, potentially at CSS, and when they're ready for that as part of their recovery, then we're going to work with them on that employment as well.
Okay. Appreciate the discussion. Thank you, Chairman.
Thank you. I don't see any other questions about COMCARE, so I guess we're ready for SCDDO.
Okay. Page 460 of your budget, there are the state statutes that are guidelines for the creation and establishment of the CDDO, and their mission is to assist people with intellectual and developmental disabilities, or IDD, and I'll refer to some of this stuff as IDD, to receive quality services and achieve greater independence. The strategic results that are identified for them in our strategic plan include that by 2019, 80% of the individuals with IDD living in the community experience life according to their preferences as described in their individualized plan. And at the end of 2017, we had 81% of folks were meeting those expectations through their plan. And the other measure is that 20% of the individuals with IDD currently living in an institutional setting, and that's generally Parsons State Hospital, transition from that setting into a less restrictive community-based environment. The baseline for that is 45. In 2017, there were 45 individuals for our community that were living in Parsons, and so we're going to continue to work with them, their families, their guardians, and Parsons to see if we can help them transition back into the community. and then work with local service providers to help them stay in the community. The CDDO's vision is that disabilities will not limit us, and they focused on 3 different things that they work with their network. The CDDO is a little bit, every service model across the human services array is a little bit different. The CDDO is primarily a care management organization. They determine eligibility for people into the system, but the care is generally delivered through partners across the community. There's 50 different CDDO or organizations that the CDDO contracts with for the delivery of services, and so they have a network that they need to work with, and as long as that network is sufficient, then the CDDO doesn't have to be a provider of services as well. And that, I think, is the model, and that model was chosen a number of years ago. The Commission advocated that we not become another service provider, but we do manage the system and the network, and we continue to do that. But again, our goal is to not have to keep the network strong so that we don't have to be service providers as well. And so, in light of that, Dee has worked with the network to develop a trauma-informed system of care. Individuals with IDD often experience trauma, and so it's important to be aware of that through the treatment process. We want to meet the needs of individuals with co-occurring disorders, particularly behavioral health needs, and then provide leadership as this system goes through a number of changes. They have a number of different programs, including operations and subsidized living, service access and outreach, quality assurance, state aid, administration finance, and then capacity development. In terms of the property tax funded programs at the CDDO, the operations and subsidized living function is the one that that's where the property tax funds are spent, and that is to make sure that we have available at any time through contracts access to residential and day support services for people that are experiencing crisis. And so in 2017, this funding supported 586 different individuals, and we partner with Arrowhead West, Catch, ResCare, and Starkey, and we do that to make sure that they have available resources to bring people out of settings that are inappropriate and get them immediately into some type of residential or day programming that's appropriate for them. And so that's how we make sure that we don't become a service provider. Service access and outreach is a non-tax funded program, and that is the single point of entry into the IDD system. And so staff there determine eligibility, they make referrals, they provide information and then make referrals to those service providers in the community. And there were 2,520 individuals eligible for services in 2017. And so these staff are doing eligibility determinations, and then periodically they need to do redeterminations for eligibility. The quality assurance program is funded through non-tax funds, and they do a number of different things to make sure that the services that are being provided are appropriate and safe and adequate for the individuals being served. They do that through records reviews, desk audits, they do on-site visits, and then they work with organizations to develop quality improvement plans if there are concerns, and they try and help guide some of the training that goes on as well. There were 2,145 of those folks receiving services also had those services reviewed by quality assurance. And I mentioned those 50 affiliate providers that our QA staff are working with on a daily basis to make sure that the services are appropriate and that they're meeting health and safety guidelines. State aid is another state-funded program, and it is funding that is available for some unique and special circumstances. It's available to address some transportation needs, children's services, some folks that may not be eligible for Medicaid that may need case management, and then flex funds. And there is there's an application process that case managers and families can go through, and then there's a review committee that looks at those requests and then makes determinations on how those state funds are allocated to address this variety of different needs. And then there's an administration and finance program that is responsible for that, maintaining those contracts and making sure that services are available for those 2,500 individuals that are eligible. The capacity development program is one that Dee instituted a few years ago to try and partner with service provider organizations to make sure that the network maintains its adequacy. And so she has done RFPs to give organizations an opportunity to say, here's what we need help with, and we want to partner with you. And so Dee will partially fund different programs. So she'll match funds with them to help them do initiatives. Starkey built another facility, a very nice day program facility a few years ago. In 2017, they asked for some funds to help with a staffing and retention initiative that they needed to start. One of the biggest concerns for the IDD industry is there's a pretty high turnover of caregivers, and so that can be very disruptive for the individuals receiving services. And so Starkey wanted to work on retention and attraction of new employees, and she also partnered with Rainbows to do something very similar. So the budget request for the CDDO and property tax funds is $1.95 million, and on the non-tax side it's $3.3 million, and the total request is $5,308,842, down slightly, and there are the superior commitment items. In terms of system capacity in particular, you can see that the number of eligibles remains the same, and the unserved, fortunately, is going down a little bit. And one of the reasons that the number of unserved is going down is because over the last 2 or 3 years, the state has made some additional funds available to help bring people off of the waiting list. And so as those additional funds are identified, the State Department KDADS then sends letters asking people if they're ready to, if they want to come off of the waiting list. And one of the things that we have seen over time is that more people are receiving those wait list offers. So they're being notified by the state saying there's funding available to bring you off of the waiting list. And now, particularly last year, we've got more people accepting those offers. Over the wait list right now is about 9 years. Is that right? 8 years from the point in time that somebody's determined eligible to the point in time they get through the 8-year waiting list to be funded. But now we've got more people accepting those wait list offers, and so that drives the decision package one of the decision packages that we have for the CDDO. This is going to be on Dee's grant fund, but she would like to continue her capacity development program. She uses state funds again to work with the network to see what kind of needs they've identified, because we want to be able to address folks as they come off of the waiting list and make sure that the network is adequate. And so, as I mentioned a few years ago, Starkey needed an additional facility to do some day programming. Dee partnered with them on that. This past year, she's worked with a couple of our very large service providers, Rainbow and Starkey, on some employee retention issues. And so she'd like to make this funding available again to work with the network to make sure that we're able to adequately serve those folks as they come off of the waiting list. And we don't know yet how that money would be spent, because Dee will do an RFP and figure out what's the best use for the network. The other decision package is one that is more time limited, and this is a general fund request, and this relates to transportation. One of the things that I think we've heard as kind of a recurring theme, and then you'll hear from me later on as well, is transportation is an issue for people in poverty, and particularly for people that are in services sometimes with some of the programs that are the divisions of the Public Services Department. Transportation is an issue. And the service providers for the CDDO system were impacted by a city decision a few years ago where they took there was a reduction in funding available for the city bus service, and it impacted paratransit and some of their transit services. And it has had a negative impact on the CDDO the DD providers and their consumers. And so they have approached a number of different systems looking for some relief. And what Dee would like to do is do an RFP this fall and see what types of solutions the network comes up with in terms of providing additional transportation to individuals. And then maybe if this decision package is funded, she would have $250,000 to apply to that problem. And we anticipate that would just happen in 2019 because the city of Wichita has indicated that there are things changing on their horizon, and that by 2020 they may be ready through some work that WAMPO's doing to be able to pick up to provide some additional assistance to DD providers. But the bottom line is the transportation network in the community is inadequate. The paratransit system in the community is inadequate. Medicaid transportation only pays for transporting individuals to medical appointments, not necessarily to day programming and things like that. That is very important to people receiving services in the IDD system. And so this funding would allow us to assist those individuals to get to and from programming that's important to them in their daily lives. Dee has a story, an individual story, that's tied to a young man who I think was a Project Search graduate who, based on some of that experience, was offered a full-time with benefits job at Wichita State University. The young man happened to live in the south part of the county, maybe Derby, and he unfortunately had to turn that job down because there was no way for him to get to and from his job. And that's the reality for individuals sometimes with disabilities. One of the other things that negatively impacts folks in the IDD system is it's not uncommon for individuals to need to have their support worker with them to help them make that trip wherever it is that they're going. And paratransit and bus systems aren't really designed to transport two people at once. And if they do transport someone to help someone get to their day program, then you've got a staff person that's at a day program that doesn't need to be at the day program. They need to go somewhere else. And so it's transportation for individuals with developmental disabilities, very complicated, and we would like to see some additional resources to maybe try and help solve that.
Okay. Commissioner Unruh.
Thank you, Mr. Chairman. First, I just want to say that I'm pleased that you and Dee have included this budget request. It is really a serious problem for that community, as you described. But my question is, $250 doesn't get us much, does it? I mean, how is that even to do anything that's sustainable?
It's a start. It's a start. Do you want to come and talk to that a little bit?
Good morning, Commissioners. Apologize for the voice. I have a little bit of cold. $250,000 isn't very much, particularly when I had 5 providers who were contracted with the City of Wichita that lost $1.2 million in subsidy on an annual basis to support their transportation. But I think Tim referenced sticker shock earlier. I think we requested a modest amount that we felt we could try to help our providers leverage some of their own resources to try to create a solution or some pilot projects that might create a variety of different solutions to try to address the issue. It is extremely complicated and way outside of my area of expertise. This particular year, we currently have an RFP for a study specific to transportation for the IDD population over in purchasing right now that we're getting ready to release, to have an outside entity help us really further understand the full impact on the population as it relates to public transportation. But you're right, $250,000 isn't very much.
Well, thanks for that answer. I know that that particular community, those consumers would be extremely pleased that we're doing anything to try to address the problem. And, well, I don't want to make a comment about the city's ability and their system and all that sort of stuff. I'm just glad we're trying to assist with a solution, so appreciate it.
Thank you. Commissioner Howell.
Thank you, Mr. Chairman. Just going back to the one of the first comments you made, you said there was 50 partners?
Yes.
Okay, that's more than I realized. I'm curious, is that including both the residential and the day programs?
Yeah. Some of them are large and significant, and you may be aware of, like Starkey and Catch and Rainbows. And there are some that are very small, and they may serve just a handful of folks, a few staff, and serve a handful of folks. But yes, that's both residential and day providers. We've got some providers that only provide day services. Some providers serve both residential. If they provide residential, they commonly provide.
Are there
day
more
services
providers out
as
there
well.
are there more providers out there in the community potentially, but they're not part of not our partners, and so there's 50 is what we partner with. We contract with those 50, but are there others out there that we're not connected to?
If there are, and a consumer wants to choose them, there's a process to make them part of that system, so that we would go to 51. That number kind of varies from the high 40s, the high 40s to the mid 50s, depending on whether or not someone chooses, because the individuals receiving the services have choice. And if they pick a provider that maybe we haven't contracted with and that isn't yet licensed by the state, we'll work with them to get them contracted and licensed.
So back to the transportation question, then I'm aware that there's a number of IDD folks in Derby that are having to go to Wichita to get day reporting services, or day services, excuse me. And there's at least one individual trying to open up a day service there in the city of Derby, and it's having trouble getting going, I guess. I don't know if we're connected to the LifeWorks program or not, but if we're not, we are.
They're already affiliated with us.
Okay.
So Lisa's ability to open her services in Derby, it really just her.
Okay. So anyway, so we're connected as much as we possibly can, equally. Okay. Want to make sure that we're doing what we can to make sure that one happens, and so okay. And are those day programs, are they property tax funded or okay?
No, it's Medicaid, home and community-based services waiver funded.
Okay, but going back to the wait list, I was curious about that as well. You mentioned 8 years, but that's for the HCBS waiver. Are there people that are needing, so Sedgwick County IDD residents that need services that can't get them because they're on that HCBS waiver waiting list? Is that correct?
Correct. There are about 930 individuals right now that are Sedgwick County residents that are unserved by the home and community-based services waiver. Some of them may have Medicaid coverage, which gives them access to targeted case management services. If they are connected to a targeted case manager, or if they're not, and they have a need for, let's say, in-home support services for a family that has a child. We do have the state aid services that we fund, and the family could come and ask for some assistance. So we do try to provide some access to limited resources through the programs that we allocate out through our funding committee process. But again, it's strictly limited to our state aid allocation, so.
Okay, so
it's limited funds.
I understand. So are we tracking that 930 to see how that changes over time?
Mm-hmm. Yeah, we do. We track them very closely.
Which way is it trending right now?
A little bit down. You can see from the slide I think Tim showed around the wait list. In 2017, we had 61 wait list offers from the state here for Sedgwick County. That was probably the biggest number of wait list offers that we've had since I've been at the CDDO 6 years. So they're coming off very slowly. To be honest, we don't go out and do aggressive outreach or assertive outreach into the community because the waiting list is so long, and we have very little to offer families while they wait.
Is that list a first on, first off type of list, or is it
No.
based on needs?
Both. So the waiting list managed by the state is based on wait list date. So it's kind of a first on, first off type of a thing. There are some very limited exceptions to the waiting list. So if someone is in crisis as it's defined by the state policy, we can make a recommendation to the state that the individual be given immediate access to the waiver and enter services. And that's why we have our sub-live program, so that when we do have individuals that have that kind of need, we can get them immediately into services.
So those residents that have the greatest, I'd say maybe a critical need, that there's just no family help, so they can't solve the problem. They absolutely need that kind of help, and they would probably be prioritized in that way, and hopefully they would be at the top of our list, so to speak.
It's possible. It depends on the specific circumstances, because the state has very narrowly defined what a crisis is.
Okay, well, okay, I think that's all my questions. Thank you, Chairman.
Thank you. Commissioner O'Donnell?
Yeah. Well, either of you, with the transportation, I've read where other communities are using app shares like Uber and Lyft and things, because we don't necessarily need to build an infrastructure of public transportation. I know we had a very limited discussion about this the other day regarding bus transit into Oak Lawn and about how many people use it. But if we know exactly who the users are going to be, you would think something like that might work.
There are a lot of communities that are moving to microtransit and using those types of systems. We don't know enough about it, and that's why we're working on the RFP to release to have someone do a study to help us identify not only the gaps, but also possible options for us to consider. Then we plan to do an RFI at the end of the year, once we have the results of that study, to get some ideas for how do we want to invest the limited amount of money that we hope we get through this budget request process, to then invest in some pilot initiatives. And we continue to look for those kinds of opportunities. Johnson County has a very unique partnership between one of their developmental disability organizations and their community mental health center, providing employment opportunities for the SPMI adults to provide transportation on a limited basis to some of the IDD clients. So there are some creative solutions out there. We just need time to be able to identify those, and also expertise from people who really understand this very complex system to help us
I understand.
Find some solutions.
Yeah, and I understand. I mean, transportation is critical in a city like Wichita, Kansas, where we don't have a robust public transportation system. And the chairman and the manager, I introduced both of them to Lyft and Uber while we were in Washington, D.C. for the Association of Counties, and they were able to see the benefits of that and how much cheaper it was than like traditional cab service, or much more efficient than the subway. So I'm just thinking if that's something you could look at, you can identify the individual and make sure that it's being used to take them to work or whatever. It would, I think, be strategic and beneficial.
Tim actually brought to me an idea that he learned about at an ICMA conference, where I believe it's Lone Tree, Colorado, has a program, a microtransit program for people with disabilities using Uber, and a specialized vehicle. So there are ideas out there. We just need to have someone who has the expertise help us identify what the best potential is. And the city did hire a new transit director who I think has a pretty big list of things to work on.
Sure. And in cases where there's city transportation already, that's great. But as we learned with the Oak Lawn situation, or other people living outside of the city of Wichita, or even within boundaries of the city of Wichita, they don't have bus service anywhere near them. And if they have a physical limitation, it's going to be impossible for them to get to the bus stop anyway, where Uber or Lyft will go directly to their driveway.
Right.
So,
yep, absolutely.
All right, thank you.
I don't see any further questions on SCDDO. I think our next subject is aging. Commissioner Unruh is very interested, since he's retiring next year, and he wants to learn how to play pickleball.
I don't even know how to respond to that.
I thought we would go the
But
whole budget without pickleball being mentioned.
I'll be thinking about some catty response.
I'll try not to interrupt those thoughts. We're on page 473. The mission for aging is to assist seniors, caregivers, and persons with disabilities to achieve improved health and greater independence. We'll cover programs including administration, community-based services, in-home services, physical disabilities, and the ever-important transportation. Again, aging works to help individuals remain in their home and in their community, and they work with the seniors themselves, with their caregivers and persons with disabilities, and they do what they can to help improve the wellness of the community. And their strategic results, as identified in their strategic plan, include that by 2019, 85% of seniors will be able to stay in their homes. In 2017, that number was 95%. And another strategic measure is to help individuals realize $225,000 in cost savings through the SHIC program and the insurance counseling that they provide. And they were able to realize $301,000 in 2017. And that 35,000 individuals receive information, referral, and assistance services to help them remain in the community. And they helped 42,000 folks in 2017. The Aging Administration is funded through both property tax and non-property tax funds, and they again provide the infrastructure needed to help support the network of services that are available. And we talked a little bit about how the CDDO manages services. The Division on Aging delivers services directly, and they also manage a number of different services through partnerships with other providers. And they collected over $1 million in ADRC, which is Aging and Disability Resource Center services in 2017, and they managed $1.2 million in transportation grants as well. Also funded with property and non-property tax funds are the community-based services, and those are services that they served over 20,000 individuals with mill levy funded programs in services including senior centers, adult day, prescription drugs assistance, the RSVP program, and legal services. And then they also served 14,500 folks with grant-funded programs including congregate meals, caregiver support, nursing home assessments, and then information assistance and referral and options counseling when it appears to be time for a family to maybe help someone into a higher level of care. Community-based services is also where we fund our senior centers, and 22,800 seniors were served in that particular setting. Our in-home services are funded both with property tax and non-property tax funds, and those services are again designed to help people avoid that transition into a nursing home. They were able to help 515 folks in 2017. And they do that with case management, some home-delivered meals, homemaker and attendant care services, and minor home repair. And those are all important services that may be the one thing that will keep someone from needing to go to a nursing home. The Physical Disabilities Fund is funded through property tax funds, and they serve 645 different individuals, and this is primarily through contracts with other service providers in the community, and it's for folks that meet that PD criteria. Transportation utilizes both local funding and state funding, and they provided almost combined 29,000 rides to individuals, to appointments, medical appointments, to other appointments, and to help them do the things that they need to do in the community so that they can maintain in their homes. The budget request for the Division on Aging is $3,008,295. That's down slightly. And there it is by program, the non-tax funds. And so your total budget request is $10.7 million. And from a data perspective, this is national data, but it impacts every state in the country. And if you look at it, there are age categories 65 and older, 85 and older, and 100 and older. And these are numbers in thousands. And you can see there is a steady progression from now until 2060, anticipated increases in all three of those age categories. And some of the most significant growth, percentage-wise, is in that 100 plus. So The demand for services we anticipate will continue to grow. Based on that anticipated growth, the Aging Advisory Board has recommended some decision packages. The first one is to add some additional resources, $55,000, to in-home and community-based services. And again, those services are primarily provided by contract. Annette and her staff identify needs, identify service providers, and then contract with those folks to deliver services to people who need that to stay in the home. There's a similar request for PD services for $45,000. Embedded in that $45,000 request is $7,600 that was added mid-year in 2018 for CPRF therapy services. So we made a mid-year adjustment, and so this decision package request would be for the department to continue to fund that, and then some additional resources for other folks that meet those PD criteria. And then the final decision package request is for some additional funding for senior centers. There are, as you may know, I'm not convinced that our current funding model or our former funding model is sustainable. And so I'm looking for a way to maybe transition away from that into something else, and we haven't clearly decided what that something else would be. But there are 4 different senior centers that have performed at a level higher than they're funded right now. The Advisory Council recommended that we present to you another decision package request for the same amount, $78,000 that you'd seen the past 2 years, and that would have fully funded their requests. And I decided that I would make an alternative proposal, and that is for those 4 centers, I would request that we increase their funding to each of them by 20%, and the total funding request then is $21,200. And that again would help us transition from the old funding formula that we have into something new, but it would be an opportunity for us to draw a line in the sand and say we've moved beyond the old funding formula. We're recognizing the additional services that you're providing, and we're doing it through this additional funding, but we're going to transition away from that old funding model into something else. And Annette and her staff will continue to work to find a formula that makes sense to her staff and to all of you. But I'd like to make that transition from what we've done in the past to something different. And so that's the basis for this request.
Okay. Questions on aging?
Pickleball.
Pickleball. Make sure we have a training program for Commissioner Unruh. Thank you. All right. I guess we're ready for Department of Health.
Health begins on page 500. There are a number of different either ordinances or statutes that support the work that they do. And 2 slides worth, in fact. The mission of the Division of Health is to improve the health of Sedgwick County residents by preventing disease, promoting wellness, and protecting the public from health threats. And they do that through a number of different programs, including administration, preventative health, children and family health, and health protection. Their strategic results as part of the strategic plan include that 85% of reportable diseases and conditions are investigated in a way that's consistent with KDHE guidelines and regulations. For 2017, 95% of those investigations met those KDHE guidelines. And their other measure is that no more than 7.8% of the babies born in Sedgwick County are born with low birth weight. And the measure right now for the current 3-year average is 7.8 babies were born with low birth weight. Administration, again, property tax funded, and it provides all the infrastructure and support that the rest of the division needs. They also, within that budget, they have funding for Project Access. Project Access is a program that's administered by the Central Plains Regional Healthcare Foundation, and it is designed to gather volunteer and donated services and materials to provide health care to the uninsured in the community. And in addition to Sedgwick County United Way and the City of Wichita also provide funding. And Project Access was able to serve 1,149 individuals and also manage 2,633 donated tests. Also within the administration function is our central supply. They manage all of the medications and vaccinations that the health department needs. They handled 21,000 vaccines in 2017. The preventative health program is funded with both property tax and non-property tax funds, and they do that a number of different ways. The family planning program served uninsured and underinsured women, and their goal again is to prevent low birth weight, premature birth, and to help families space birth in a healthy way. And they they delivered 5,445 office visits to almost 3,000 clients. The maternal and child health program provides family planning and STI clients under the age of 22 with services, and they served 881 individuals in 2017. The STI, the Sexually Transmitted Infection Clinic, serves individuals who have been diagnosed with an STI, and they try and help the individual through treatment and making sure that that is not spread. And they did over 7,000 tests in 2017, and they served 1,900 individuals. The immunization program, they provide vaccinations for contagious diseases to adults and children, and they also provide travel vaccinations. They do TB tests, blood pressure checks, and they do other health screenings for individuals. They provided almost 20,000 immunizations to over 8,000 clients last year. Customer service manages a call center for the health department and manages the med record function. They served 14,000 folks. It is one of the places where we have some bilingual folks because a number of the folks that the health department serves speak Spanish, and so we're glad to be able to provide those services in Spanish as well. And then the health department within the preventative health division has a lab service, and so it supports all of the different health services, including on-site testing for STI, and it's just very helpful and convenient for both the individuals and the service providers to have that lab on site to be able to get those results immediately. The Children and Family Program has two primary components. One is the WIC program. That's again a partnership with the state. They served over 20,000 women, infants, and children in 2017. And the primary goal of the WIC program is to make sure that we don't have those low birth weight babies and that babies get the nutrition that they need as they start off their life. And it serves kids up to the age of 5. The Healthy Babies program is again designed to help the occurrence of healthy pregnancies and healthy deliveries and follows children through that second birthday. And in 2017, they served 1,312 moms, dads, and infants and toddlers, and that represented 6,000 different encounters. The Children's Dental Program is a volunteer program. We've got some staff that are hygienists, but they primarily work with volunteer dentists to deliver care to individuals, to children between the age of 5 and 16 that are uninsured. And the value of those dental services that were donated is over $110,000. And our dental clinic is also a training site for dental hygienist students from WSU. And so we're using staff and some students to do that work. They also go out into the schools in the community and do dental screen on kids, and they screen 17,000 kids. And if they identify concerns, they'll work with the school nurse to help that student get referred to either their own family dentist if they have one, or back to the dental clinic if they don't have access to their own dentist. The Health Protection Program includes the STI control program, and these are the folks who do the actual investigation. They go out and they try and track individuals and their partners. Once an STI has been identified, they try and make sure that they figure out where it's gone, make contact with those folks, make them aware that they're infected, and work with them to get that infection addressed and make sure that it doesn't spread any further. And they performed 1,500 investigations last year. The TB control program is housed at our clinic on East 9th, and they served 357 clients in 2017, 10 with active TB, but they work with all of the folks that may have concerns about TB, and then the folks who do have TB. They do directly observed therapy for most of those 10 active patients, and they'll either do that on site, out in the community, or we continue to use televideo, and so they're able to observe individuals take the medication before they go to work or whatever it is they're going to do for the day. Cuts down on that transportation need for folks. And then we've got the Public Health Performance Program, and that primarily does two different things. One is that it works with the community and the data involved in the Community Health Improvement Plan, and the other thing is that they work with a number of volunteers that are community health advocates that go out into neighborhoods and communities and try and encourage individuals to find a medical home through our staff train volunteers, and then they go out and give presentations and encourage folks at churches, at neighborhood initiatives, neighborhood groups, try and help individuals understand the value of identifying a medical home and getting regular medical care. Also under health protection, we've got our epidemiology program, a number of really smart scientific folks who monitor and track disease. They're in constant contact with the healthcare network in the community, so they're talking to doctors' offices and to hospitals and emergency rooms, and they're tracking, monitoring for different infectious diseases. And if you want to know what the health of the community is, the EPIs that work there can tell you. They communicate constantly with those healthcare providers. They did 1,300 disease investigations in 2017. And then animal control is part of health protection, and they did over 2,000 field calls, and that involved 54 different bite investigations, and they're available to, they work with a number of the small communities within Sedgwick County as well as the unincorporated areas. And health protection also includes our fetal infant mortality review program, and so that is where we have a staff person gather a number of different healthcare providers, a number of different aspects of the healthcare system to look at infant deaths, try and figure out if there's any system issues that may be contributing to those deaths, and then make recommendations either to the system or to individual healthcare providers. And they did 22 reviews last year, and they made 3 different recommendations based on those reviews. So from a property tax funded budget request, those are the programs that are funded. The request is $5.1 million. From a non-tax budget request perspective, it's $6.9 million, and you can see that most of that goes to the 2 children's programs, Healthy Babies and WIC. In summary, we've got a property tax request of $5.1 million and a non-property tax of $6.9 million, so a $12 million request for health in all funds. I have a couple of different decision packages for the Division of Health. One is health educators. One of the things that we see is that in this community there are 3 different issues where we are above the state averages in terms of prevalence, and those are in sexually transmitted infections. Over the past 5 years, we're consistently above the state average in terms of prevalence there. Diabetes, it continues to be a problem in this community, and I think our rate is 9.9%, so that's impacting over 37,000 folks in this community. And then smoking continues to be a health issue in the community. And so What Adrian is asking for is some additional health educators that would be able to attack those three different issues. One would potentially go out and work with in a number of different settings and communities on the sexually transmitted infection issue and try and make sure that individuals understood the consequences of behaviors that lead to infections and how they could control the spread of those infections and maybe get us back in line with the state. And then also to address both smoking and diabetes, because there just aren't enough smoking cessation or diabetes management programs in the community. And so 2 staff, $137,000 would address that particular need. And this is not a revenue package, it's a decision package, and it is tied to the reaccreditation process. In 2014, the health department became the second health division in the state, the health department in the state to be accredited, and that was for a 5-year period of time. The fee for reaccreditation is due in 2019, and so much like we try and reassure the community with our EMS and our Regional Forensic Science Center accreditation, we want to send that same message to the community that we have competent staff that are interested in continuous improvement, providing our health division of health services as well. And so that's the value of accreditation. And the request would be for $16,000 in 2019 for reaccreditation, and then ongoing there will be an $11,200 reaccreditation fee each year. But what that does, it allows Adrian and her staff to continue to work with the accrediting body to make sure that the processes and the procedures that they follow are of the highest quality and meet the current standards. And so that's the basis for that particular request.
Okay. Do we have any questions over the Department of Health? We move on to Lake Afton.
Okay.
Commissioners, do you want to take a break?
Probably good time for a break. It's 10:30.
Okay.
Why don't we take a
Once
2-minute break?
again, I want to go on record. I'm not the one that asked for it.
I'll ask a couple questions if it's okay.
Oh, we'll ask a couple questions.
I'm going to ask this one because I know Commissioner Ranzau wants to know the answers. So, who does the accreditation of the health department?
Fab.
The Public Health Accreditation Board, which is a nonprofit funded by the Center for Disease Control and Prevention and the Robert Wood Johnson Foundation.
Are we going to do anything different than we're doing right now to get that, to receive that accreditation?
Well, we are continuing, which accreditation does is really helps us look at, they help us assess our strengths and any areas needed for improvement, and it gives that added focus to continue looking at ensuring that our services are driving quality through quality improvement and performance management and specific outcomes. And this round for the accreditation is not so much sending them all of the documents and procedures and policies, some of which we created because we found that there were processes that we had that really weren't documented. And so that was a huge part of the initial accreditation. And this reaccreditation is about not showing them that we have those MOUs and policies and relationships with our community partners. It's about describing, we have to write a lot of narratives about how we connect with the media, how I educate the Board of Health, just really digging down into our processes to make sure they are clear, understandable, and that we have them, that they are in line with the national standards and just how we need to be operating.
I guess I'm just curious why we don't like do a self-assessment type of thing. This is $16,000. I'm curious. I mean, we can find lots of ways to spend $16,000. To let somebody else give us an approval that we can basically do a self-assessment, know what's needed to make our services great or whatever. I'm surprised we would want to spend that much money on.
We certainly could, and we do. I think one of the advantages to the accreditation process is it is a formalized, identified and recognized set of questions and review to do. And when we're done, it allows us to communicate with everyone else that we've met that criteria. I think there's a difference between saying we continue to look at our work and we do good work, and having someone else say, we've looked at the work that you do and we've assessed it against all other health departments and this set of standards.
Does this accreditation qualify us?
And you do good work.
I'm sorry, does this accreditation qualify us for something that we don't, in other words, does it open a door for us to do something, maybe receive a different grant, or does it do something for us that somehow benefits Sedgwick County if we were to have the accreditation?
One of the reasons that the CDC worked with to create the FAB to do accreditation for health departments is because they have indicated it's their intent in the future that they will make funding decisions based on whether or not organizations are accredited. And so we believe that by maintaining our accreditation, it will make us eligible for things that we wouldn't be otherwise.
When do we first receive accreditation?
In 2014.
Pardon me?
2014.
2014. And we're not accredited now?
We are accredited.
We are accredited now. Okay. And how many other health departments in the state, or what's the percentage of health departments around the area that would be
I'm not
accredited? I mean, are all of them accredited, or
Certainly
something?
not.
In
No.
2014, we were the second health department in Kansas to become accredited, and there are currently 188 accredited local health departments throughout the country, 144 others in the process of becoming accredited. KDHE, the Kansas Department of Health and Environment, just recently became accredited, and there are 31 accredited state health departments, and ours is one as far as KDHE, and then 8 in the process. And so more and more are doing what they can. Some health departments, it's very difficult because of the size, and if you have frontier and rural health departments that maybe have 5 people, it's difficult for them to meet all those standards. So they're looking at doing some regionalization with some of those. But yes, it is the move to become accredited to show our community that we have met all those high standards.
Okay. And we know what the standards are.
We do.
Okay.
Both of them, yes.
Okay. Going back one slide, or I guess 2 slides. The health educators, isn't this the same program that we eliminated a couple of years ago, or?
Well, the health promotion programs division, it was eliminated. 5 staff were eliminated at a pretty short period of time. These health educators that I'm asking to add are different from the ones we had, because some of those services were picked up by our community partners. And so what I did was met with many of our community partners to find out what the needs still were in the community, because I didn't want to reinvent the wheel. And through meeting with partners, found that there was a need for more diabetes management programs. There are maybe 20 people trained to really do the evidence-based model for diabetes management, but they mainly do 1 class a year. And so I met with the head trainer in Kansas, and she said Wichita has a shortage of diabetes management for our residents. So that's why I decided to add a position that would do part of that training. And then the other would be smoking cessation, because they're just lead calls around the community, and unless someone is in alcohol and drug treatment, there are no smoking cessation classes that we should find.
I thought the program that we eliminated it in 2015, I think it did go to the community. There was a smoking cessation grant, I think, that moved. I thought that the community picked that. You talking about a community partner picked that program up, and they actually got the grant funds for it.
They did. Our grant went to a different partner, but that was for those 2 tobacco educators weren't focused on smoking cessation for individual people. That chronic disease risk reduction grant that we had for decades is focused more on community level interventions. Like, one they did recently got together a bunch of teens and went to neighborhood parks and counted the number of cigarette butts that were very close to where young children were playing. So they do those types of interventions and then provide information to the community about this is what's going on at our parks where our young children are playing. And so they create interventions like that, or working with schools to do smoke-free grounds. So it's more community interventions that grant and those educators are focused on doing.
Okay, so is this going to be property tax funds?
Yes.
Okay. And I assume that the accreditation is also property tax funds?
Yes.
Okay. I probably have other questions, but I may go to another way to discuss this later on with Adrian. So that's all I have for now. Thank you.
Thank you. Commissioner Renzo?
Yeah. You said 188 counties or health departments were accredited. Out of how many in the United States?
I will have to get you that number. And then 144 more in the process of becoming accredited.
Means it hundreds, thousands? And did we do this because, I don't remember a groundswell of the public complaining that we weren't meeting any standards at our health department?
No. And I don't know that the public complains about other bodies that are accredited not meeting standards either, but we strive as businesses and services to ensure that we are doing the very best that we can. And this board, Public Health Accreditation Board, gathered people from around the experts in public health around the country and helped establish these guidelines that all health departments could follow to show that they were working on continuous quality improvement and establishing very objective and quality performance measures.
Weren't we doing the best that we could before that?
We were, but you know what? It wasn't, we didn't know some of the things we didn't know.
And the people who actually work there, the healthcare providers, they're licensed, they have professional organizations, they have to do CMEs and their standards and protocols of performance and all that sort of stuff, right?
They have to remain licensed through their education, but the bodies don't necessarily establish quality outcomes that they have to follow as far as nurses. There are standards, right, but they don't come into the health department as far as how we are providing services. They have to retain their licenses.
Right.
But as far as the processes and the relationships we have in the community and how we're involved, those are separate from, and accreditation is helping us advance some of those relationships and processes.
Like what?
Well, looking at who all the partners we have and the need to get some unusual partners at the table versus just public health, that we need to look at doing a better job of having community members at our tables. That's one of the things that we're working on. And with the health educators, ensuring that I wasn't going to, and I would have done this, but that I wasn't reinventing that wheel, meeting with as many community partners as I could to see how we, the health department, could help support the work that they're doing in the community. And the biggest thing, again, is having a formalized quality improvement program, because we did not have a formalized quality improvement program where someone underwent a lot of training in quality improvement and then came, hired them with the health department and as part of what the role was, and then began slowly, and we're still doing it because it takes a while, but incorporating that into our culture so that we do have a quality improvement team, and we have an expectation that our programs are looking at projects that they can work on, and that's outside of it. It's really easy to get focused on the services that you need to provide and not be thinking of, just because something works well doesn't mean it can't be improved. And so that's one of those processes that accreditation has really helped us to continue to look at
We
above
can't-
and
we-
beyond.
We can't do continuous quality improvement without the federal government, the Robert Woods Johnson Foundation kind of dictating how we operate and setting standards for us. I mean, this is the problem. I mean, we don't need to keep going on, but this is a top-down approach, okay? Robert Woods Johnson Foundation is a very progressive organization that wants to promote socialized medicine. You want federal government to control operations. This is a waste of money, okay? If we can't do continuous quality improvement ourselves that you're talking about, then we have a problem here. And you know, a very small percentage of the health departments in the community in the nation are accredited. And I'm not going to support wasting more money on this issue. We'll have to agree to disagree, but I'll tell you, if we can't do some of the basic things you're talking about, and I think the benefits are exaggerated. I mean, we need to focus on the services. We provide good services, and some of these basic questions you're asking, it's just, you know, we've talked about accreditation in a lot of different organizations, and I'm not going to relinquish control, or I'm not going to support relinquishing control to outside organizations, which is ultimately what the goal is, so they can change the standards and say you got to tie it to money. So.
And we will continue to do quality improvement. I mean, that is established as a goal, and we will continue to do that. Part of this is the recognition in the community that we are an accredited health department like other accredited
Who
businesses.
cares about that?
The community that we're
Who?
doing.
The people coming in for sexually transmitted disease tests are going to care about that. They don't even know about it. They don't give a squat about it. I mean, it provides nothing. I mean, let's just be realistic. They don't care. I mean,
Our partners, it means a different, but
your partners
like you
are going to be your partners no matter what.
Like you said, that this is one of those things that we agree to disagree on.
They may operate under the same illusion that this is meaningful and helpful. So, but I mean, I don't. It doesn't help anything. I mean, they're going to be our partners no matter what. So let's not relinquish control to the federal government and the Robert Woods Johnson Foundation.
Okay. I don't see any further questions, but why don't we take a break?
Thank you.